Good evening to all of you. Today, this is our 10th webinar on how to attempt ENT OSCE stations. So we have two speakers. One is Dr. Manoj Agarwal sir and Dr. Vishwas sir. Manoj Agarwal sir will be taking on the MRI basics, and Dr. Vishwas will be dealing with rhinoplasty and how to do a counseling for rhinoplasty and all the questions in the domain of rhinoplasty. So let me introduce Dr. Manoj Agarwal sir. Uh, Dr. Manoj Agarwal has a special interest in otology and lateral skull base surgery. Dr. Manoj Agarwal has done his MBBS from Calcutta National Medical College. He has completed his MBBS in '96 and he did his ENT from the same college. He is a gold medalist in every aspect. He was awarded the Devjani Banerjee Memorial Medal for in Anatomy, Physiology, Biochemistry, and Ramchandra Sen Memorial Award for Biochemistry. He has won R.N. Roy Chaudhary Gold Medal Award, Major K.K. Ghosh Memorial Award, and he has also done his DLO RCS. He has completed his DLO RCS examination from Royal College of Surgeons of England. After doing his ENT, he was very fortunate enough to complete a scholarship grant from Professor Mario Sana, director of Gruppo Otologico in Italy. He is also recipient of PHR Junior Consultant Award in 2004. Uh, Apart from academics, he is also very Bollywood. He's a very big Bollywood fan, and he was the semi-finalist of Bollywood Ka Boss on Filmy Channel, which was conducted by Boman Irani. So we already had a session with Dr. Manoj sir. So now I would request him to give us some insight on how to understand a basic MRI scan. So Manoj sir, up to you, sir.
Thank you so much, Dr. Prateek. Thank you for that wonderful introduction. Good evening, everyone. Good evening, Dr. Vishwas. Good evening, Dr. Sriharsha. And without wasting much time, I'll dive straight into the discussion. So can I start sharing my screen now?
Yes, sir. Yes, sir.
Okay. Right. Thank you. So two disclaimers. I'm an ENT specialist, not a radiologist. And though I have a special interest in radiology, so while I'll try and give you the basics of reading of MRI, there could be a few questions here and there, especially the technical aspects, which I might not be able to satisfy you with an answer. And two, this is only the temporal bone and the bare basics of an MRI. It's very important for us to know the bare basics of an MRI. I will not be touching upon either the neck or the paranasal sinuses because that's not my area of expertise. So first and foremost, what does the MRI stand for? Actually, the MRI term itself is a misnomer. It stands for magnetic resonance imaging, whereas the original term was NMR, nuclear magnetic resonance imaging. The word nuclear was removed for the simple reason that the word nuclear, as in whenever it's used, it gives it a negative or a more dangerous connotation. So, so keeping that in mind, the word N was actually removed and it just stuck onto MR imaging, that is rather than an NMR imaging. Now, let's take each of the three words. Nuclear magnetic resonance. What is it exactly that we are doing here? Why is it called a nuclear magnetic resonance imaging? You see, the whole purpose here, the whole idea here is to study the nucleus of the hydrogen atom. It's the hydrogen atom which is there in literally every tissue. Human body is 70% water, and in each water molecule has two hydrogen atoms. Fat has hydrogen, carbohydrates have hydrogen. So it's basically the nucleus, though there are other molecules at other atoms which as well can be studied, but the basic NMR or the MR studies that we look at, they study the atom or rather the nucleus of the hydrogen atom. Now the nucleus of the hydrogen atom is made up of a single proton. There is no neutron. It has to be an unevenly charged proton, so a nucleus. So it's a single proton. That's why these hydrogen atoms in NMR terms in magnetic resonance imaging are also called protons. In fact, in the earlier parts and even now, once in a while, you might come across an MR image which says proton density weighted image. So where does the term proton come from? Proton comes from the fact that the hydrogen atom, the nucleus of the hydrogen atom is made up of a single proton. So it's basically synonymously used. And there's a third term which is synonymously used for the same proton or the hydrogen atom proton, and it's called a spin. So these terms, the hydrogen atom proton or the proton or the spins, they are used synonymously, though not necessarily correctly. Now, why are they called spins? On a quantum physics level, the proton is supposed to be undergoing a spin at every moment of time, though it is random. It's not something that can be visualized. It's not something that is actually physically happening, but it is happening. And that's why these protons from the hydrogen atoms are also called spins. So that takes care of the word nuclear. Magnetic, why? Because we put these spins or these protons into a very strong magnetic field, align them, then remove. This is just very, very simple basic physics. Just remove the magnetic field, and as the proton atoms lose their alignment, they release some energy, which is read out by the amplifier, which is amplified and read out by the receivers. That's why magnetic. And why resonance? Because we are using the resonance that is generated. We use radio frequency pulses to change the orientation of these spins, and the energy that is emitted is the resonance that is being heard, so to say, by the receiver of the NMR or the MR machine, hence the term nuclear magnetic resonance imaging. So that's the basic, very, very basic physics of NMR. Now, in general, as I had even mentioned during my talk on CT scan, there are so many sequences. These are called sequences, okay? The protocols that are, the images that are given to you on a plate in an MR, in an NMR or an MR, or on a CD, they are sequences. The commonest ones that we know is a T1 weighted sequence, a T2 weighted sequence. But if you look at the left side panel here, look how many sequences can there be. This is a T2 turbo spin echo. This is a T2 space. This is a T1 star wipe. So there are various sequences, and at the DNB level, especially for an otolaryngology exam, you need not really know very much about these various sequences. But yes, you should know how to differentiate a T1 image from a T2 image, even if you do not have this data available. For example, right now, is my screen visible, Dr. Pratik? The software visible?
Yes, sir, it is visible, sir.
Okay. So this is very clearly saying T1 TAC dark fluid, whatever, but I can very well remove this as well. I can actually remove the annotations, and then how would you know whether this is a T1, T2, or what kind of a sequence is it? So the first things first, let's take a look at this particular image. It's the three important images sequences, or rather the four important sequences that you should understand, you should be able to differentiate, is the routine T1 weighted, routine T2, a flare, and a contrast. And I'll come to the importance of the flare. Someone had asked the question last time in the chat as to what is the importance of flare and why flare, and I'll come to that a little later. So on a T1 image, we know that the brain is made up of mainly of gray matter, white matter, and then there are the ventricles with the CSF. So a T1 weighted, remember the last time as well, I had said, please use the term T1 weighted, T2 weighted. Don't just call it a T1 image, because every voxel, it's not a pixel, it's a voxel. In an MRI, it's a voxel. In a CT scan, it's a pixel. Why? Because it's a volumated pixel, which means that actually it's a three-dimensional structure. It's a cube and not a square. So on MRI, it's a voxel, which means it's actually a three-dimensional structure. So each MR image is made up of thousands and thousands of voxels and not pixels, which are cubes I hope you appreciate this fine difference between a cube and a square. A square is two-dimensional and a cube is three-dimensional. So every voxel that you see in any image actually has all the relevant information. It's just that the sequences are taken in such a manner that a particular T1 weighted image, in a T1 weighted image, it's the T1 properties which tend to come up more than the T2 weighted properties. So on a T1 weighted image, what happens is that the brain is true to its structure, in the sense, this is the gray matter. Okay, the sulci and gyri on the surface of the brain is the gray matter, whereas this is the white matter. The core of the brain is the white matter. And on a T1 weighted image, the gray matter will appear gray and white matter will appear white. Remember, it's true to the brain structure. And CSF, because it is full of water, I mean, water kind of, it's full of a particular fluid, CSF appears dark. So I hope we are clear on that. T1 weighted image, gray matter appears gray, white matter appears white, and the ventricles appear black or hypointense, I beg your pardon, hypointense because it contains CSF. What happens in a routine T2 image? I'll just give you a coronal, an axial section rather than a sagittal section, a sagittal section rather than a coronal, because you can understand the difference much better here. So what do we see here? What we see here is, this is a T2 weighted image. See here, it says T2. Forget the TSE. The TSE stands for turbo spin echo. So on a T2 weighted image, what happens? Look over here. Look at this area or this area. The gray matter now appears a little more whiter compared to the white matter, which appears much more darker in intensity. So there is a flip. There is a flip of the intensity of the gray matter and the white matter, and it sort of reverses. The gray matter becomes whiter, whereas the white matter becomes darker and grayer. So that's one way of knowing that it's a T2 image, and obviously the CSF within the ventricles is hyper intense. It's bright in intensity. So that's normally, that is how most of the time, even with a distant view, we are able to say that, okay, this is a T1 weighted image or a T2 weighted image. But there is something else as well, and that is called a flare image. That is called a flare image, wherein, look again, the gray matter. Now, don't go by the absolute intensities of the gray matter and the white matter, but look at the fact that the gray matter appears whiter than the white matter, which means it's a T2 weighted image. See, it says here. It says here it's a T2 weighted image. But if it is a T2 weighted image, how come is it that the CSF has become hypointense or dark in appearance? It's because of a technique which is called flare sequence, which is an acronym. MRI, NMR studies are full of acronyms. So the flare study means, it stands for fluid, FL, fluid, attenuated. Attenuation means you clamp it down. Fluid, attenuated, inversion, recovery image. I will not go into the inversion recovery image, but the first two words become absolutely clear to you. The fluid, which was brighter on a routine T2 weighted image, has now been attenuated to a darker image. Thereby making this a flare kind of an image, wherein the gray matter appears whiter, the white matter appears grayer, but the CSF becomes dark in intensity. Now, someone had put in a question the other day as to why would we want to have a flare image. I'll tell you why would we want to have a flare image. Look at this. This is not so much used for us as ENT specialists, other than when you are looking at the inner ear. Other than when you are looking at the inner ear, in a specific inner ear diseases like labyrinthitis, hemorrhagic labyrinthitis, or other forms of labyrinthitis where you are looking at the inner ear fluid, normally a flare image is not as much of a use to us as the neurologists. And the reason being, one of the important reasons is multiple sclerosis. Now, what happens in multiple sclerosis? You have these hyper intense plaques all around the brain globally. I mean, those hyper intense plaques could be anywhere. It could be in the cerebral hemisphere, it could be in the brainstem, anywhere. But normally it has been seen that the MS plaques are very close to the periventricular area. They tend to be close to the periventricular area. Now imagine if there was a small hyper intense plaque of multiple sclerosis here. Now, if the ventricle is hyper intense, differentiating that hyper intense plaque here from the hyperintensity of the ventricle would have been difficult. But but if we look at the flare images, now with the ventricles becoming darker, with the fluid signal being attenuated, if you have a hyperintensity of a plaque here, it becomes easier to discern, to differentiate that plaque. So that is the importance of having a flare image, a fluid attenuated inversion recovery image. This is the basic fact that you need to know about a T1 weighted image, a T2 weighted image, and a fluid attenuated inversion recovery image. You basically need to know how to differentiate them as far if it's given to you on a view box or something, because it's not necessary that you would always be able to look at these annotations that are there on the film. So I hope that this part, as far as the differentiation between a T2 weighted and a T1 and a T2 weighted and a flare image is very clear. Now, how do you go about describing a lesion that is a pathology that is given to you? Okay, how do you go about describing a pathology that is given to you? Now, most of you who are looking at the screen right now are always, I mean, you're always, you're sure, you know that for a fact that this is a huge vestibular schwannoma in the left cerebellopontine angle. So the first thing that you need to know is what is the sequence of the image. Now you can see it from the annotation that it's a T2. Forget the SPC. That's another modification of the protocol of the sequence. But you can see that it's a T2 weighted image, and the fact that it's a T2 weighted image, a normal T2 weighted image, is evident from the fact that the CSF in the ventricle and in the cerebellopontine angle is hyper intense. Okay, it's evident from the fact. Okay, now so this is a T2 weighted image, okay, of the brain. As I had mentioned, even in the CT scan lecture, that try and identify a level if you can. So you can say that taken at the level of maybe at the level of the internal auditory canal, focusing on the cerebellopontine angle, showing. Now, whenever there is a lesion, there are certain things like, you know, in a neck swelling, we've always been taught that there are certain parameters that need to be enumerated as far as a neck swelling is concerned, starting from, you know, appearance, the overlying skin, whether it's smooth, then the palpation, the temperature, and so on and so forth. So similarly, when you look at a lesion on an MR or a CT scan for that matter, try describing the lesion. So it's a kind of a globular or globular lesion which is involving the left cerebellopontine angle, the margin of which appears more or less smooth. But most important is that the intensity of the lesion itself is heterogeneous. Okay, why heterogeneous? Because at some places there are areas of hypo intensity. Okay, hyper iso. Remember, brain is iso intense and it is intense in MR and dense in CT. So brain is iso intense, air is hypo intense, and CSF is hyper intense. So we can see these areas which are darker. So these can be, though they look as if they are similar to the intensity of the brain. So we can either call it hypo or iso intense. If we call this iso intense, then this becomes slightly hyper intense compared to the brain. Do not try comparing it to the CSF. So what I'm trying to say is that the intensity of this entire lesion is not homogeneous. So you cannot say a homo intense lesion. It's a heterogeneous intense lesion or a hetero intense lesion occupying the left cerebellopontine angle, extending. Look at the internal auditory canal here, but over here you can hardly visualize the internal auditory canal. So extending into the left internal auditory canal, compressing upon the brainstem and the cerebellum and causing a midline shift. How do we know that there is a midline shift? We can see that the fourth ventricle has been shifted and it is being compressed. Okay, so it is being shifted and it is being compressed. Let's look at this. See, you can see how thin the fourth ventricle has become, and see how heterogeneous this entire lesion is. It's quite heterogeneous. Why can a vestibular schwannoma be heterogeneous and all that? We can. I mean, again, that's a very long discussion. But the fact is that when you describe any pathology, you need to describe the intensity of the pathology itself. Besides its location, you need to describe the pathology, the intensity of the pathology in relationship to the brain. So, and if it is not uniform, it becomes heterogeneous. Okay, so this is obviously a vestibular schwannoma of the left CP angle. Now, if we look at the same vestibular schwannoma, okay, in a contrast this thing, let us see how would that look like. Just give me a minute. Okay, so now how do you know that this is contrast? Though it does not say here, I had told you the last time, you can see these blood vessels becoming hyper, giving out a hyper intense signal. You can see the hyper intensity of over the dura. So this is a, and remember, gadolinium is usually used with a T1 weighted image. See, you can see the T1 weighted image. So a gadolinium post contrast image is a T1 weighted image. Okay, with gadolinium, it's a T1 weighted image. And does the heterogeneity, we now on a contrast, we know that the moment we use gadolinium in a patient with vestibular schwannoma, there is hyperintensity. So is that proven here? Yes, we can see compared to the previous sequence of a T2 image, wherein it was ISO 2 slightly hyperintense or maybe even hypointense in some areas, the lesion per se itself is hyperintense post the administration of contrast. But here as well, we can find these areas of iso or hypointensity, which means that on contrast, at least this particular schwannoma is not enhancing homogeneously. Now that's the term. Whether the enhancement is homogeneous or not is another term you have to get into the habit of using, that the lesion is homogeneously enhancing, the lesion is heterogeneously enhancing. So this is a lesion which is heterogeneously enhancing. And let me answer the question for you as to what are the reasons wherein a vestibular schwannoma might not have a completely homogeneous appearance either on a T2 weighted image or on a post gadolinium T1 weighted image. The two main reasons are: A, if there is a cystic degeneration if there is a cystic degeneration within the mass of the tumor, in that case you can have iso intense, I mean, or hypo intense, sorry, the shadows, signals within the lesion. And if there is hemorrhage, within the vestibular schwannoma, then you can have these iso or hypo intense signals within the mass of the uh, vestibular schwannoma. Okay, and so T1, T2, and a post contrast. So as I said, the four main sequences that you need to know is a T1, a T2, a flare, and a post contrast. Now, if I just show you normal anatomy images, that will not suffice your purpose, because the chances are that when you are on your OSCE station, I mean, when you are on your MRI or your radiology station, probability is that you will not be given a normal MR scan. So that's the reason why I am putting in these explanations with a specific, aim at helping you identify the uh, the pathology, rather than just giving a routine tour of the normal anatomy. Now, before I proceed further, there's another very important image that we can come across pretty frequently, and that is the cases of vestibular paroxysmia. Now, in cases of vestibular paroxysmia, what is exactly happening? In cases of vestibular paroxysmia, there is a loop, a blood vessel loop, which is pressing upon the 7th, 8th nerve complex. And when it presses upon the vestibular nerve, it leads to paroxysmal attacks of vertigo or dizziness. Now, there are two ways you can identify a vessel loop on an MRI. One is what is called a TOF, a time of flight image, okay, which is basically meant at identifying the blood vessel. So you can see that this is the basilar artery, and you can see that there is a blood vessel which comes out, which is originating from the basilar artery and taking a hairpin bend loop into the internal auditory canal. So this is a loop of ICA. But what is the disadvantage with this particular image? The disadvantage with this particular image is that it is not showing me whether it is actually in contact or at least in close proximity to the nerve. So is there any sequence that I can use to visualize both the blood vessel and the 7th, 8th complex? Yes, there is. There are two of these. This is a very, very routine question, mind you, my friends. It's a very, very routine question, that is there any way that you can identify both the blood vessel and the 7th, 8th nerve complex together on the same sequence? Now, this says space over here. This is a space sequence. Forget about space, but normally the sequences that you might be asked to answer is what is called a cis, CISS, cis, or a fiesta, FIESTA. These are the two sequences which are usually used to demonstrate both the blood vessel and the nerve, in order to demonstrate a neurovascular cross compression. So now compare the previous image of the time of flight. Time of flight is mainly used to ascertain the vascularity. So it was showing us the blood vessel, but it was not showing us the blood vessel in conjunction with the 7th and the 8th nerve. But now if we look at this particular image, we can see that same basilar artery, the same artery which is actually the loop of ICA, arising from the basilar artery, taking a hairpin bend loop within the internal auditory canal and coming in close proximity to the 7th, 8th nerve here within the canal, and also at the root entry zone. So if you are at the station and you find something like this, the probability is that it is either a cis sequence or it can be a fiesta sequence. Request you to look up the full forms of the cis, and the cis is constructive interference in steady state. And I beg your pardon, but I have forgotten the full form for the fiesta. So it's the cis and the fiesta sequences which help you visualize both the artery or the vessels, rather the artery and the nerves in the same sequence. So that's another added sequence to your routine sequences, which you should be a little familiar with. So to recapitulate, T1 weighted, gray matter gray, white matter white, CSF dark. T2 weighted image, gray matter white, white matter gray, CSF bright. Flare, gray matter white matter gray, but CSF is dark. Post gadolinium, always T1 weighted image. You do not do a T2 weighted image post gadolinium. There are reasons for that. There's something called the paramagnetism and something called the shortening of the T1 relaxation. So I will not go into that. Then we come to the sequences, the specific sequences which help us identify both vessels and the nerves in the same image, which are called which can be either a cis, or it can be a fiesta, or as this study says, it can be a space, and so on and so forth. As I said, the time of flight sequence is mainly to study the blood vessel. Why is it called time of flight? A quick word, why is it called time of flight? Because it studies the time that a particular molecule in the blood or a particular part of the blood takes to travel from point A to point B, and then it charts its course along that particular between those 2 points. That's why it's called time of flight sequence, and it's mainly used for studying blood vessels. So I think that in these 30 minutes, I've been able to cover the basics of MR, and I leave it to Dr. Prateek whether you want me to continue or whether you want me to take up questions now. Oops, 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 oops.
Sir, you can take few more minutes, sir.
Okay, okay, okay. So there is something that I wanted to else to show. Any questions till now?
Yes,
Yeah.
yes.
Yes, Dr. Rakesh has very clearly given the answer. Fiesta is fast imaging employing steady state acquisition. Thank you, Dr. Rakesh, and also Dr. Sriharsha. Thank you so much for that. Okay, then in that case, let me show you an image of an MR angiography, if that is of interest to you. Where is the study? Let's see, where is the study? The study. Yes. So this is called a maximum intensity projection. Okay, this you can see here. You can see here, this is called a maximum intensity projection, and this is basically an MR angiography. Okay, it's an MR angiography, and the advantage of an MR angiography compared to compared to a normal angiography is that MR angiography can be performed without gadolinium. I mean, just because gadolinium is used does not mean that gadolinium does not have any disadvantages. Remember, it is quite notorious for causing renal tubular fibrosis, and that's the reason why patients' urea and creatinine are always checked before the patient is subjected to a post-gadolinium MR imaging. So the advantage, as I said, of MR sequence angiography can be done in an MR using contrast. It's a contrast enhanced angiography, but at the same time, angiography can be done in the in MRI without using the contrast. And as you can see, this is a sagittal view, which gives you a wonderful idea of the posterior circulation. Though it's very difficult to see the entire posterior circulation in one go, but if you look at this, this is an MIP stands for a maximum intensity projection. As I said, the world of CT scan is much more simpler. Honestly, the world of CT scan is much more simpler. There are not so many acronyms, there are not so many terms that you need to know, but I'll not, again, as I said, I will not go into the physics, but an MIP stands for a maximum intensity projection. So this is the vertebral artery. This is the cervical part of the vertebral artery, the V2 and the V3. and then you have the V3, which is going around the odontoid process. So these are the two vertebral arteries over here. Yeah, these are the two vertebral arteries. No, I'm so sorry. I'm so sorry. My bad. My bad. Those were the carotid arteries. Those were the carotid arteries. So this is the vertebral artery over here. This is the I'm extremely sorry. Apologies for that. This is the vertebral artery. These are the internal carotid arteries. So this is one vertebral artery. This is the other vertebral artery. And as we move, we see that the vertebral arteries have joined. Okay. Now, what we see is that the vertebral arteries have joined. Okay, and then the first branch from the vertebral artery is the ICA. This is the, just forget about this. This is the internal carotid artery. So look at this. So this is the vertebral artery here, the vertebral artery, and now the two vertebral arteries have joined. So this is the basilar artery, and this is the ICA arising from the basilar artery. This is the right side, this is the left side. It's not necessary that you will see all the vessels at one go. And then this is the basilar artery, and you have a lot of small pontine arteries here. And then this is the superior cerebellar artery. The superior cerebellar artery, a quick overview or a quick recap of the entire vertebro-basilar system. You see the vertebral artery, it has four parts, C1 to C4. C1 is from its origin to the transverse process of the C4, C5 vertebra. From the transverse process of the C4, C5 to C2, to the C2 vertebra is the C2 portion. The C3 portion is from the transverse process of the C2 till the dura. And finally, the C4 portion is the intradural part of the vertebral artery. Then the two vertebral arteries, they merge together to form the basilar artery. The vertebral artery, the main branches of the vertebral artery are the pica, the posterior inferior cerebellar artery, and the anterior spinal artery. And then from the basilar artery, you have the ICA, anterior inferior cerebellar arteries. You have a number of pontine arteries. Then you have the superior cerebellar artery, and finally it bifurcates into the posterior cerebral artery, and that's the termination. And this is where the posterior part of the circle of Willis is formed, and this entire thing is called the posterior circulation or the vertebro-basilar circulation system. So even an MR angiography, so for example, if you are studying a patient of stroke, acute vertigo, right? Imaging in acute vertigo itself is a major topic. So if you're studying a patient with stroke, an MR angiography is absolutely mandatory if you are suspecting a brainstem or a cerebellar infarct, because most of the cases of posterior fossa strokes are because of some form of an affliction of the vertebro-basilar arterial system. I mean, it could be a stenotic change or a vaso-occlusive disease. The stenotic change could be because of atherosclerosis and so many other reasons. There could be a dissection, a vertebro-basilar artery dissection. So the vertebro-basilar artery has to be imaged very emphatically and convincingly in cases of posterior fossa stroke. And why are we as ENT specialists bother about posterior fossa stroke? Because these patients can present with acute vertigo. Okay. So I suppose that's about it. I'll just quickly take questions. Dr. Roshan Bonde, what is TE? TE is the echo time and TR is the repetition time. You see, what happens is that when you put in the radio frequency pulse, the spins, as I had mentioned earlier, the spins, they undergo an alignment, and after you've removed after a certain point of time, they lose the alignment and therefore give out energy. So you read or hear that energy from using a receiver. Because you are hearing that energy, that's why the word echo has come into the MR parlance, right? That is why it is called a echo time. That is, after you've given the radio frequency pulse, what is the time after which you are listening to the signal coming from the patient using your receiver? So that's the echo time. And the repetition time is Why does MRI take 45 minutes, 40 minutes, whereas a CT scan in a 128 slice machine can be over and done within 8 minutes? That's because of the various modalities that have to be taken into consideration. So it's not that you give one radio frequency pulse and you listen to the echo after a certain point of time and that's the end of it. No, you keep on giving repeated radio frequency pulses with a lot of modification. It is those modifications, not just of the radio frequency pulses, but of a lot of other parameters which decide whether you have a T1 weighted image or a T2 weighted image. Again, core physics of MR can't go into that. So the repetition time is the TR, which means the time at which interval at which you are repeating the radio frequency pulses to the patient. So I hope that answers your question, Dr. Roshan, that what does the TE and TR stand for? Functional MRI, as Dr. Prateek has mentioned, it's a huge topic in itself, and I would actually be asked to excuse, we can't do that in such a small, short span of time. DWI for cholesteatoma, I will definitely explain, because yes, it's a very important protocol, and though it's not foolproof. What does DWI stand for? It stands for diffusion weighted imaging. Diffusion weighted imaging. What are we looking at in the diffusion weighted imaging? We are looking at the Brownian motion of the water molecules. Okay, we are looking at the Brownian motion of the water molecules. Normally, even the brain has water molecules and they are free to diffuse in any which direction that they want to, though there is a caveat there. The caveat is that the gray matter or the tight structures of the white matter, you know, the tracks and all that, they decide in what direction will the water molecules diffuse. But that's in the normal situation. But what happens when there is an abnormality? DWI is mainly used for stroke. DWI is mainly used for early detection of stroke, but then that again is a major topic, but it has also been used for cholesteatoma. Why? You see what happens. Cholesteatoma is what? Cholesteatoma is keratin. It's dead skin. Okay, it's dead skin. It has no water, or rather, whatever water is there, it is trapped. It cannot diffuse out. Normally, on a DWI image, the areas will appear iso or hypo intense in the brain, or whichever part you're looking at. The areas will appear hypo or iso intense. But that's because there is normal diffusion of water in all direction, water molecules in all direction. In a cholesteatoma, water molecules are trapped because it is surrounded by keratin. The water molecules cannot diffuse out as freely as a normal tissue. Okay, so the water molecules accumulate, and surprise, surprise, it gives out a hyper intense signal on an MRI. Okay, so when you have more water molecules which have accumulated in a particular part of the brain, the DWI image will give out a hyper intense signal, and it is called restricted diffusion. It is called restricted diffusion. Okay, so that is what the concept of DWI is. But there is a but here. Then while doing a DWI imaging, there is something very important called a B value. The B value is basically, it depends upon the strength of the magnetic field applied, the duration to which it is applied for, and the thickness of the slides. Since you've asked me about DWI, you have to know, because I don't want you to go home or go back with the wrong message that any DWI sequence will give you a hyper intense restricted diffusion for cholesteatoma. No. If the B value is kept to a very, very low level, say between 0 to 100 or 200, there will be no hyperintensity of cholesteatoma on a DWI lesion. On a DWI image, there will be no restricted diffusion. The B value has to be 1000, 800 to 1000, which means, if you just recollect what I said a while ago, which means that the magnetic field gradient, the strength of the magnetic field that is being used for a DWI image, has to be much more stronger. There are ways wherein our radiology friends do that. So that is how a DWI lesion appears hyper intense because of restricted diffusion. But since I have mentioned DWI and someone asked for DWI, there is also something which goes hand in hand with the DWI, which is called the ADC map, or the apparent diffusion coefficient map. Again, it's studying the diffusion of the water molecules, but it is exactly reciprocal of a DWI image. It's exactly reciprocal. An area from where the water molecules can diffuse out very fast will have a high ADC value. Therefore, that area will appear hyperintense. On the contrary, an area where the water molecules cannot diffuse out very easily, that area will have a diffusion coefficient which is low. And so the intensity of the lesion of the signal on the image will be hypo. So if we look at it in totality, a cholesteatoma on a DWI image will appear hyperintense because the water molecules cannot move out. And that same cholesteatoma, provided the B value is 1,000, right? Provided the B value is 1,000 per millimeter square, and that same lesion will appear hypointense on an ADC map, because simply the diffusion coefficient of the water molecules there is lesser. They are unable to diffuse out. So in fact, reading only an ADC, only a DWI image can sometimes give you a false impression, especially in cases of stroke. In stroke, it's the same philosophy. When you have a stroke, when you have an infarct, blood has got collected in a certain part of the brain. Water molecules cannot move out from there. There is edema, water molecules are trapped. Therefore, hyperintense lesion on an MR, ADC map, hypointense lesion. So I hope that answers the question for Dr. Parth. Cisternogram, MR cisternogram, basically a heavily T2 weighted image. I'm not talking about the cisternography, which is done by injecting a contrast into the intrathecal region, but basically these days a heavily weighted T2 image. A heavily weighted T2 image, for example, something of this sort, a heavily weighted, this is not really an MR cisternography, but still a heavily weighted T2 image, wherein the cisterns, what is cisternography? You want to see the cisterns. What are the cisterns? The cisterns are the CSF containing spaces of the central nervous system, that is the brain and the spinal cord. So anything that helps you see the cisterns clearly is an MR cisternography. Anything else, Dr. Prateek? I think I have overshot my time.
Yes, I think there are no other questions, sir.
Okay.
So
Okay.
if participants have other questions, they can directly put it on the group, and I will ask Manoj sir to answer it.
Okay.
Yes.
So thank you very much for
Yes.
your patient listening. Thank you.
Thank you so much, sir. Thank you so much.
Bye.
Manoj sir, it was an excellent talk. I mean, there are a lot of points that I learned today. Thanks for giving the talk on MRI.
Thank you so much, Dr. Vishwas. Thank you. Thank you.
Yes, sir. Sir, we will move to the next session. So let me introduce Dr. Vishwas Vijayydev, sir. He has completed his graduation and post-graduation from prestigious institutes in Karnataka, and he has also completed DOHNS from Royal College of Surgeons of England in UK. He has received further training as a clinical fellow with medical registration in the domain of facial aesthetic and reconstructive surgery in UK at Doncaster Hospital, NHS Trust. He is also a recipient of Baco Fellowship Award by ENT UK. His areas of interest are rhinoplasty, fat grafting, implants for better facial profile, dimple creation, cleft lip palate surgery, facial trauma surgery, and so on. He has won many awards at national and state level meets for his presentation, and he is also recognized as an upcoming researcher by ICMR, JNCASAR, and awarded various scholarships. On the academic front, he has been the course and invited guest faculty in various teaching forums for facial aesthetic surgeries. He has also authored several chapters in facial plastic surgery textbooks. Dr. Vishwas aims to bring the best practices followed around the world to Bangalore in the field of facial cosmetic and reconstructive surgery. He strongly believes that aesthetic surgery should be available to everybody irrespective of financial status, and hence runs a surgical camps to benefit the unprivileged. So I would like Dr. Vishwas sir to start the presentation. We are also having a poll. So Dr. Vishwas will instruct us to start the poll. If you have any doubt, you can ask the question on the chat section.
Well, thank you so much, Dr. Pratik and Dr. Sriharsha, for inviting me over to share my teaching sessions with the DNB students. I just need some help with the sharing of the screen. While I'm pressing it, I'm not seeing the video clip. So do you want me to open it and close it again?
Sir, can you try it now?
Yeah, just so when I put the share screen, I can only see two options. I'm not seeing my PPT. Just hold on.
Sir, you have to open
Show
the
all windows.
PPT before, then click share screen.
Yeah, it's open on the tab. It's open on the tab.
Just close it and open it once again.
Yeah, I think I'll do that once. Just give me a second.
Yes.
Sorry for the delay. I'm just trying to link in. No, I'm not able to see it yet. I can see the presentation on the tab here, but I can't see it.
Sir, you can also start sharing by advanced settings and just go on portion of screen. That can also help.
Okay, you feel that's better?
Yes, sir. So you can stretch. Yes, sir. The
So
green.
you can see that.
Yes, sir. We can see, sir.
So do you want me to stretch that as well?
Yes, sir. Yes, sir.
Can I draw on the screen as I explain?
Yes, sir. Yes, sir. Yes, sir. Now we can see, sir.
I'm here pulling it to the entire extent. I hope I cover the screen on top as well. Well, thank you. I mean, on a Thursday evening, all of you are tuned in to listen to this rhinoplasty OSCE session. I'll try to make it as basic as possible for all of you here, but do promise me that you will interact with me as I go on, because it should be more interactive, and then I should not be the only guy talking on the screen at this moment. So rhinoplasty is a surgery which has been there for centuries for us. And Indians have been doing it, and then it went to the West, and then it came back to us, and now there's a very good rhinoplasty teaching going around the country. So it's mandatory for all students to know more and more about rhinoplasty. Basically, you need to understand that it's all about structure and additionally the function that is involved in rhinoplasty that you need to correct. Most importantly, when you're building the structure, as you see in this building, you need to provide sufficient struts. And can you see the marking on the screen that I did? Dr. Pratik or
Yes,
Dr.
sir.
Sriharsha?
Yes,
You could see that marking on the screen that I did?
Yeah,
Yes, sir. Yes, sir.
Good. Okay. So what we need to know is the struts and the supports need to be as stable as possible. One. Second, we need to make sure that whenever we load something on top, before we load something on top, we need to make sure that we have the supports correctly. So this is what, as students, you need to know about the structural rhinoplasty. And there are very more terms regarding rhinoplasty called as augmentation rhinoplasty, reduction rhinoplasty, then preservation rhinoplasty, extracorporeal septoplasty, and various other forms. But for you, in the basics, you need to understand something called a structural rhinoplasty. Now, I'll just try to open the poll number 1. Can you open the poll number 1, Dr. Sriharsha? So the question is, what is the most important counseling point as far as rhinoplasty is concerned? So we have about a minute's time. I think it should be appearing on your screen. So please go ahead and answer. So what we are seeing is a great educated crowd here. So I need to teach you more because you are already into the counseling session. So I'll go into a little bit of nitty-gritties of counseling that you may or you might not have experienced. But 44 seconds have passed and I can see that most of you are given the right answer, probably all of you, 100%, that you give a realistic picture to the patient. So I'm sure you all understand that rhinoplasty is a surgery in brackets wherein you cannot absolutely say you can get your hearing back. So you can share the results, Dr. Shriasha, so that everybody can see what they have polled. So giving a realistic picture is the most important thing as far as rhinoplasty is concerned, because as was said by Dr. Eugene Tardy himself, even after 20,000 rhinoplasty, he was yet to do the perfect rhinoplasty. So we are all students for life. We are not going to be perfect in our rhinoplasty. At some point, we will feel, no, that result could have been better. And that's the best way to be, because the day you start feeling that you have done the best, that's the day you stop growing. So, sorry, the slides are stuck. Yeah. The most important thing that is also, as ENT surgeons, we need to know is to talk about the function with the patient. You might be giving a beautiful nose, but if that does not function, then there's no point in that beautiful nose at all. An additional added layer is the psychological assessment that you need to do for all your patients, because we have many patients who come to you, at least 30-40% of my practice, who really do not need a surgery or probably are imagining a defect, and they need to be rejected outright. If not, you are going to have a lot of litigations on your hand. So I'm not trying to scare you, but this is the way the rhinoplasty works in facial aesthetic surgery. Now, the aim of analysis is threefold. First, you be a mathematical person, establish the deformities and formulate a plan. That's the simplest part. The second thing is, all the time we are looking at the nose. We need to be looking at the face also. We need to look the other things like the shape of the face, the type of the skin, the width of the forehead, the width of the chin, the angulation of the chin, and many other things, whether any other procedures need to be done to enhance the harmony. So the purpose of rhinoplasty is to actually make sure that the attention is taken off the nose and the people look at your eyes and talk. So what would happen after a perfect rhinoplasty that you would do is they will forget about the nose and start thinking about the cheek and the chin, and then they'll tell you, doctor, something is wrong in my face. I'm not happy with the way you've done the nose. So you will need to always counsel your patient regarding the additional structures on the face and tell them accordingly. And the most important thing that you all realize is the giving the realistic outcomes. Somebody might come to you and say, give me Hrithik Roshan's nose. You can definitely say, no, that is not possible, because his skin structure is different, his cartilage structure is different, his height, his face, his angulation, everything is different. We cannot recreate it, although we can create something closer to it, but we can never recreate it in 100%. So these are the points that you can actually take a photograph. You need to do a personality assessment. You need to know about ethnicity. The skin type is different in the various regions of India. The angulations of the nose are different in various parts of India. The dorsal height is different in various parts of India. And accordingly, their tastes are different, because somebody from South India might have a big alar base, and if you try to narrow it too much, it might look too pinched in. So you need to design the nose as per the ethnicity as well. Now, the height of the patient is important, because if you have a short patient, less than 5 feet, then there's no point in giving a very long nose, because it looks awkward. If you have a very tall person, let's say at 6 feet or higher than that, even if you give a long nose, it suits well or fits well with the facial profile and the height itself. Now, the skin per se, you need to understand the skin types for a mild thickness, moderate thickness, and the very thick skin, based on which you need to give your medications pre-op. You need to make sure your grafts are given well in space to create the actual requirements. And mind you, thin skin is the most dangerous to operate in, or rather for youngsters or amateurs like you. If you operate on thin skin, you need to be absolutely perfect with the contours. If not, it will show through the thin skin. Now, the facial analysis is also something very important. Now, each of us have a face wherein the left half and the right half are never similar. And what would happen is patient will say, whenever you have done a rhinoplasty, a perfect rhinoplasty, they will then start noticing the asymmetry of the face. Or let us say some of us have a mild ptosis, or a brow which is drooped down, or a lip which is not symmetric. These analysis also come into play. For example, if you have a very wide forehead, then a nose, even if it is long, it will look short. So you will need to understand that there are certain ratios in the face that needs to be matched at. Now, I'll just deal with the psychological analysis a little bit because this has been asked sometime in your examination. Now, multiple consultation is almost the rule nowadays because you tend to understand the patient and the patient surrounding and the expectation and the people who come with them. Now, patient must be able to define the dislikes. Whenever the patient comes to you, if they're not able to tell you what they want in their nose, at least ask them to tell you what they don't like. And then you give them some pointers and then ask them to go back, research and come back, look at their face and come back. But don't ask them to take selfies because selfies tend to distort the face. Now, you need to be aware of something called as a body dysmorphic disorder, because these are patients who feel there is a bump when there is no bump, or there is a slight elevation or depression when there is not much of an elevation depression, because the mental imagery is such. Though physically there isn't anything, they're always feeling something wrong with the body. Now, this is a slide, you can all take a photo. This is from Rorik and Janice Kinnell. These are the pointers to be very careful of. Such patients you need to avoid. Some minimum disfigurement if you are especially a youngster who's starting off, somebody with an identity issue, body image issue, confused motives. If they say that I know I like my face, but people around me don't like my face, my confidence is low, I'm not able to work because of my nose or my face looking like this, or I am going for a job and I need to look good for the job and I need to do better at the job. This is something you need to be wary of. And history of poorly established relationships, and whether they blame their present misfortunes on their physical appearance. They feel they're short and then they're not able to be competitive enough. And if they're starting to blame a lot of authorities, starting to blame a lot of doctors for what they have done, a history of seeing multiple physicians or having paranoid thoughts, please avoid such patients. One or two important mnemonics that you can all remember is Simon and Sylvia. Now, Simon are the patients whom you're not supposed to operate. That is single, immature males who are over expecting, narcissistic, they love themselves so much, and dissatisfied always with their own appearance. Even if God would come and carve their face, they would be dissatisfied. So those are the Simons. They are the ones you need to say, no, I won't do the surgery. The Sylvias are the ones who you would like to do the surgery. If you can see the mnemonic here, can you see me drawing it here? Sylvia, they are the secure young listeners who are quite verbal. They know what they want, they know what they don't want, they're quite intelligent and pick up whatever you say. For example, if you say, I'm going to put a spreader graft to make sure that the valve is open, but your nose is going to become wider. If they accept that, they are intelligent enough because they're following what you're saying. And if they're attractive, well, it adds to the total package. So you will need to be making sure that you avoid the Simons and you make sure you pick up the Sylvias for your surgery. So most important point for you will be to do a balance. Now, patient has a certain expectation and your expertise has to come up to that level. Or if you are not able to deliver to that level, you tell the patient that you're only able to deliver to that point and they should match. Only then you should do the surgery. Otherwise, it becomes a big patient communication issue, even though you give a nose which looks very good to you. And especially so in revision surgeries, you will need to be guarded because many times there are external factors. You would have done a perfect job and draped the skin, but the skin heals in a different way. The cartilage might contract in different manners. Now, going on to the analysis of the patient, the first and the foremost important point that gets the patient to you is their photographs. Okay, so we can have the second poll here. Patients are always happy to take photographs with their cameras or like to look themselves in the mirror. Dr. Shriyasha, we can have the second poll question. So they like to look themselves in the mirror, and they like to look themselves in the photograph and see in all angles, possible angles, and then see which is the best photograph that they can put on to their digital profile, social profile. But trust me, medical photography or the photography that you need to analyze is to be done with an SLR camera. It is not to be done with a mobile camera, because the mobile camera has something called as a fisheye lens, which I will be showing you later. Now, almost, okay, only 10 about 10 or 45 have voted. We expect more to be voting now. Yeah. So predominantly what happens with the fisheye lens is it gives a very magnified and rounded appearance to the face, and patients look plumpy, bulky, nose looks plumpy and bulky. So we will need to have a lens which shows the absolute figure of whatever is there on the face of the patient. So the poll has almost ended now, and half of them have voted, more than half of them have voted. Maximum have voted for 90 millimeters, which is actually wrong, because, yeah, you can close that. And 22% have voted for 50 millimeters. You can close that, yeah. So the most important lens that you can use is a 35 lens or a 50 lens. So that is the one which is going to give an absolute representation of whatever is shown in front of the lens. And that is the one which gives the correct shadows and the contours. And we need to preferably use that on an SLR camera. So it's always like this. Life is always about how we see things. Yes, nose is also about how we see things. So it could be a profile view or it could be a frontal view if you break it down. So the photographic analysis has to be done in this manner. You can take a photograph of this image here. So you can have a photographer in front of the patient and a background which is usually dark blue or black without much of mirroring or reflecting, and that should be a straight image without any kind of contrast or no checks pattern. And the subject should be usually seated on a revolving stool, and the patient should not be having makeup or glasses. Okay, you ask them to remove makeup and glasses and then sit comfortably and make sure the head is in the Frankfurt plane, that is the infraorbital rim and the root of the helix matching each other. Only then you're supposed to take the photograph. Sometimes if the patient is lifted up, you will see the lower part of the nose, but you'll never see the dorsum part of the nose. So the light arrangements need to be positioned at 45 degrees angles here. You can see here the flash number 1 and the flash number 2. You can see it here, and they need to be called as the shadow lights. So you can get the two lights shining on the patient and get dorsal aesthetic lines. These are the ones which are required. You need to stand at a distance of 1 meter to 1.5 meters and adjust your lens accordingly. If you have a 50 lens, it will be much closer, which is actually called as a flat lens. Now the standardized views that I'll be showing in the next few slides. Do you see those red marks in the screen still? Dr. Shriyasha or Dr.
No, sir.
Pratik?
No, sir. No, sir.
Okay, okay, that's great. So this is the frontal view, which is a standard view for rhinoplasty. This is how we analyze the patient. So we need to look at the facial proportions, that is the proportion of the forehead to the nose to the chin and cheek, skin type and quality. We need to look at the symmetry of the nose, something called as the dorsal aesthetic lines, that is the lines which pass from your brow point to the tip and wideward. Then we need to look at the bony vault here. This is the bony vault. Can you see the red markings as I'm doing on the screen?
Yes, sir. We can see, sir.
Yeah. Then you need to look at the mid vault. Then you need to look at the tip. You need to look at the alar rim. You need to look at the alar base, and you need to look at the upper lip. At this juncture, I would like to thank Dr. Hina Bakshi for sharing photographs of her sister, who has agreed to share these photographs on the screen because it will be usually live and most of them can access it. And I would like to thank her for sharing these photographs because we could not get any patients to share these photos. So this is how you analyze the facial thirds. Okay, normally the point between the anterior hairline to the glabella and from the subnasal to the glabellar point or the nasion point should be equal to the mentron. So these three should be equal to each other, and this is what you're supposed to look in the asymmetry. This is called as the symmetric thirds, or you call it as a vertical thirds. There is another thing called as the horizontal fifths. So you need to see that the width of the eye from the medial canthus to the lateral canthus should also be the intercanthal distance, and should also be the distance between the lateral canthus to the root of the helix, or the sideward projection of the hairline itself. Now this is also to be very well assessed. Now sometimes what will happen is, if the patient has a very low dorsum, so this point or the intercanthal point will look very, very wide. It is actually an illusion, and you will see as you see in the clinical photographs. And ethnically, we need to know about the type of skin. Thick skin, there are a lot of problems. Thin skin, I already told you. If you have thick skin, even if you put a pin underneath the skin, it will never show up as a good projection. It will show only as a thick skin. Because of the edema and the inflammation being prolonged, you can have major bumps and elevations and depressions until the full healing up to 6 months. And it can also lead to unfavorable aesthetics, because the subdermal tissue can contract in various angles, can have unfavorable healing on the surface. Now, symmetry is something that I talked to you about. The left side and the right side may not be similar. Like in this photograph, if you see, this is the actual image of the patient, and this is the image of the patient with the right, left, which has been put together. Okay, and this is the image with the right put together. Right, so then you can see that the face is totally different. So you need to make the patient aware that this asymmetry exists, because later they'll come back and tell you've done something with your nose or my face because I was under general anesthesia and it looks wrong. Even if you show them the preoperative photographs, they won't believe you. You need to put it down in paper. Now also there is another thing called as a vertical asymmetry and a horizontal asymmetry. Now, if you look at this patient, the midpoint of this patient's glabella is not the midpoint of the lip. Now, let us imagine you do a surgery to get the nose onto the midpoint, or you get it straight. Still, it never comes into the midline of the lip. So the patient will keep complaining of that if you had not pointed out this point at all. And there is something called as a horizontal obliquity as well. You can see that not in this patient, of course, you can see that the brow line is not parallel to the nose line. So even if you get a nose line which is straight parallel to the ground, he will still feel that you have not done a good job. So you need to make sure you tell the patient, and if the patient demands an adjuvant procedure, for example, any correction with the brow or any correction with the lip, then you need to do those procedures additionally. Now, dorsal aesthetic lines, when you throw the shadow lights from the side of the photographer, are lines which are thrown from the medial brow point to the tip. Okay, and this brow tip line has to be continuous and not broken. And this is what most of us will observe in our patients, or most of us observe in our face whenever a patient walks in. So dorsal aesthetic lines are very important to be established. And one good point you can remember for your exam is spreader grafts will help you establish good dorsal aesthetic lines and a dorsum which is straight itself. Okay. Yeah. So the next thing that you need to look at is the base bony width. Now, if this is the alar width, okay, the bony width should be only about 70 to 80% of this base alar base width. If it's too wide, it looks like an awkward nose. Okay, and any deviations, any asymmetry should be noticed at this point. So these are the two nasal bones which will be there. You can see that one of the nasal bones is asymmetric, one is more slanting, one is straightforward. This you can do by palpation. Now, middle vault is usually formed by paired upper lateral cartilage, one on the right and one on the left, and the cartilaginous septum in between. There can be asymmetries even at this point, which you need to be noticing. So the nasal tip has to be triangular inverted triangle like this, and it should be well defined. So the tip defining point should be here, and you should have an inverted triangle at the infratip lobule, and you will have a midpoint here which is defined as the tip. Hopefully you can see what I'm showing, Dr. Pratik. Those dots there.
Yes, sir. Yes, sir.
Okay. So these are the things that you need to analyze in the frontal view. Now alar rims, the patient alar rim, this is the alar rim that you're seeing, that needs to be defined, and that looks like a gull in flight appearance. Now just going back, can you see that the alar rim on this patient is higher on the left side? It could be due to retraction, and sometimes some of the patients have a alar rim which is high upwards, and that can be called as a parenthesis deformity. So you can note this down, parenthesis deformity. Okay, so alar base, as I mentioned to you, this width is the alar base from the alar facial crease, and it should be equal to the intercanthal distance. Usually, though it's not a standard, usually it is between 65% to 70% of the nasal height. Now, what happens is, this is the alar base width. There is something called as a alar flare as well. Now, this width here is the alar flare beyond this line. So that is also something we need to be noticing. So when the patient smile, what happens is there is a pull on the nose, and thereby the alar base might increase, the flare also might increase. You can see that the flare has increased on one side. Now, another problem with the smiling is there is a muscle called as the depressor shift. This is an important question for you. That's the one which pulls the tip of the patient down when the patient does smile. And many patients in South India don't like this, and then they want it corrected. Actually, we can do it by cutting off the attachment of the depressor septi with the maxillary spine and the columella. So when you go to the profile view, this is called as the profile view. You need to assess these points. You can take a photograph of this slide. One is the nasofrontal angle. This is the nasofrontal angle and the radix. This is called as the tip projection, the point from where it projects onto the face and it goes forward. This is the tip projection. Alar columella relation. So this is the alar and this is the columella. There's a certain relation we need to know. Then there's a lip and the chin relation. The lip and the chin relation in the profile view. Periapical hypoplasia, that is hypoplasia at these points. Nasal length, dorsum and the supratip area, and something called as a tip rotation. If the nose is like this, or whether the nose is rotated upward, or whether the nose is derotated downwards. So these are the things to be looking at. Now, if you look at this, this is called as a nasofrontal angle, 135 to 140 degrees in most of us. And what we need to know is sometimes the forehead may be slanting forwards. Then what happens? The angle becomes acute. If the forehead is sliding backwards, then it becomes more obtuse. So you need to always assess the forehead before you assess the angle and the nasal dorsum as well. There's another point that you need to know. Normally, we are always talking about the nasion and the glabella. There is another point called as the radix, or the deepest point on the nasal dorsum, and that should usually correspond to the supratarsal crease. Okay, that point is where the nose should actually be starting, and most of the time we don't assess it correctly. And if you look at this patient, her nose is starting much below. So an ideal nose should be starting way up at the supratarsal crease. So this nose definitely looks shorter as compared to the wide forehead or the elongated chin. So this is something you need to be aware of, and you need to correct it accordingly. So this is the diagram to show you what it means to have an ideal radix point or the ideal point of the nose. So high would be something very high. It looked like a Greek nose. What do you mean by a Greek nose? When the radix point is too high or the starting point is too high. And low is when it is opposite the cornea or opposite the lash line. Supratarsal crease, that is the point where your nose should be starting. Now nasal length and the dorsum are a very fine ratio. The nasal length should be 2/3 of the midfacial height. So if this is the midfacial height, it should be 2/3 of it. So that's the usual ratio. And I also did mention about the thirds already to you. And it also depends upon the critical starting point. Now, this was the radix point. This is just a morphed image to show you how from the lower point we can put a radix graft and make it look longer and much more well defined. Now, this area is called as the mid dorsum and this area is called as the supratip. If you can see, there is a mild shallow here, or rather a hollow here, and there is a hump-like deformity here. This can actually be a pseudo hump because if you look at this point, sorry, yeah, if you look at this point here, if you elevate this point to, or rather project this nose, this hump almost vanishes. So this is more of a pseudo hump because the point below it is under projected. Rather than trying to remove this hump here, try and adjust or get the projection better. So this will come with experience as you do more and more, but this is something for you to be remembered. Now, what is tip projection? It is the anterior-most point of the tip from the face. So how do you measure it? So if you have a vertical line drawn to the upper lip, the line will bisect the nose or the nostril. So then you should have 50 to 60% of the nose in front of this line. That's a good way to remember the tip projection. As you can see, it's not well projected. Now, what is tip rotation? It is also measured by something called as a nasolabial angle. Although these are two different points, for the sake of simplicity, I'll just keep it at that. So nasolabial angle is the line drawn to the midpoint of the nostril aperture. This is the nostril aperture, and a line drawn perpendicular to the Frankfurt horizontal plane. So the angle which is formed at this point is called as the nasolabial line. This should usually be 90 to 110 in the females and absolutely 90 in the males. We do not want an upturned nose in males, or we do not want a too much downturned nose in the females. So this is something for you to remember. Females, it's usually at 90 to 100, 110. Males, it should be absolutely 90 or even 85 degrees. So why is this important? So what this tells is if the nose is rotated upwards like this, then it is tip rotation. If the nose is downwards like this is tip derotation. So you need to remember these 2 points when you're attempting your OSCEs. Yeah. So another thing is an ala columnar relation. These are very finer points. Now it's a line bisecting the nostril. So you will need to know that 2 millimeters to 3 millimeters of it needs to be the columella show. The columella which shows under this line is the columella show. That should be about 2 to 3 millimeters or 2 to 4 millimeters in some population. Otherwise, you can put it as a 1 to 2 millimeter above the line for the ala. So what can actually happen? If you look at this diagram here, we can have various forms of this. If you have a line bisecting like this, the ala could be retracted up. This is the ala, or the columella could be hanging down, as you can see here. So in the combination, you can have both the ala and the columella retracted more than the required length of 2 to 4 millimeters. This is something for you to be remembering. So periapical hypoplasia is something like this. You will see that there is a maxillary retrusion, there is a premaxillary retrusion, and there is hardly any zygomatic eminence here. So this is what we call as a premaxillary defect or periapical hypoplasia. The lip-chin relationship is also important. If you draw the ideal length and tangent to the upper lip, the vermilion should be the anterior most point here. But in this, you can see that it is matching well, but in most of our patients, it never matches. Now, if you look from the alar base or the basal view, you can see the nasal projection. That is this, the projection of the nose. You can see the columella itself. You can see the nostril shape and symmetry. You can see the alar base, and you can look at the alar flaring. I hope it's clear so far. I don't want to be confusing you with too many terms. I'll just go through it again. Yeah, so you can have the nasal projection. This is the projection from the face, and then the nostril shape and symmetry. This is the columella, and then the alar base and the alar flaring. This is the flare. Okay, this width is the flare. This is something you need to know. So nasal projection always exists in a triangular ratio. So you need to have an equilateral triangle with a 2:1 columella lobular ratio. Means to say, if you divide this line into 2/3. The columella should be 2/3 and the lobule should be 1/3. So if it is different, then you're going to have a very wrong looking base. So the nostril should be teardrop shape and should be symmetric. It should be pointing towards the soft triangle. If you have a convex alar rim, the flaring might be too much. If you have a concave alar rim, it will look like a pinched nose. So one thing you need to remember is once you draw the facial crease lines here, the width of this flare should be less than 2 to 3 millimeters. If it is more than that, then we say that the alar flaring is more. Another important view is the oblique view and also the helicopter or the skyline view from top to visualize the straightness of the dorsum. You also need to do an endoscopy to look at the valve area. Here you can see that the valve is closed and here the valve is open. Sometimes there will be septal perforations. You need to measure it and adequately account for it. So this was what I was telling about the fisheye effect. The mobile phone photography is on the left side. You can see that this looks all swollen up and you can see that the cartilages are very prominent. It shows the nose out of proportion. Although this is an advantage to aesthetic surgeons like us because it gets the patient faster to us, but it always is the wrong analysis because it makes the nose look too big on the face and you will always think that you need to reduce the nose. But if you look at the whole face itself, probably if you reduce a little bit and make sure this dorsum is taken care of, you can give a good nasal profile. Now, software can be used and it is very useful for explaining to the patient, but if the patient asks for a record and is going to use it in the post-op to compare the results, it's going to be a problem for you. So you can decide what you need to be doing with this, but they are in the market now. There's 3-dimensional photography and simulation software as well. Another important thing is the rhinomanometry, that is the active or passive and the acoustic rhinomanometer. We are using this rhinomanometer to make sure or at least measure the nasal flow through the airways because many a times patients do complain that they cannot feel the air passage in their nose. What happens temporarily after the surgery is the nasal nerves which are supplying the mucosa are not able to sense the flow because of the injury or the surgery, and patient will keep telling that the nasal block which existed earlier still exists, they can't feel the air flowing. Even after 6 months, some of the patients have an altered sensation of nasal airflow and they might not appreciate it. So you will need to provide an objective evidence of the nasal airflow improving with your surgery. Otherwise, you're going to land up in a lot of issues, especially so with revision surgeries. So the graph to be remembered is this. If it is closer to the x-axis, then the airway is obstructed. So X means airway is obstructed. Y means yes, the airway is not obstructed. So you will need to get a yes or a y-axis for all your graphs. That is, if you get this kind of a graph, then you are safe. So in your exam, if you're asked which is the closer one, the y-axis should be a yes answer for a good airflow. Okay, then you can also do an acoustic rhinomanometry to see the level of obstruction at each point, the way it is reflected from, the sound is reflected from inside. So to conclude with the analysis, it's not only analysis, importantly, you need to match expectation to the outcome and you need to have a plan which is carried out intraoperatively as well. Now, I'll just go through a few more slides just to give you a basic of how rhinoplasty is done. I won't be getting into the mathematical modeling. Dr. Pratik, are we good in time?
Yes, sir. Yes, sir.
Okay.
Yeah, good, sir.
So these are something called as the Gunter's charts. Please write down the word Gunters. Gunter's charts. These are meant to be marking out what you do intraoperatively. And if you can see here, there is something called as a domal creation suture. Can you see this domal creation suture here? These are the domal creation sutures that we create. So what they do, for example, if you have a very wide dome, you put sutures here and they create the dome and they actually pinch it up for us. So they create the dome. Okay. Now what is, sorry, this one. Okay. Now domal equalization stitches this. So sometimes what happens, one dome is higher, one dome is lower. So what happens, you need to take one dome up and one dome low to get it equal. So you put a domal equalization stitch. Okay. You can have an interdermal stitch as well, and this also can account for an interdermal stitch. You can see that here also you can have an interdermal. Usually these are interchangeable, the dermal equalization and interdermal. Now, another important thing is the lateral crural convexity suture. Sometimes what happens is the lateral crura is too convex, you need to make it concave, or concave and you need to make it convex. So you put the lateral crural convexity stitches out there. Now, if you look at the drawing itself, you can see that these dotted lines are the osteotomy lines. This is the fascia shown in the gray. Then you can have the graft shown in the dull brown here, and disc cartilage can be represented, and the resection usually is pointed out in this fashion, in the reddish, because red is for removal. And additional grafts can be shown in this fashion. So this is how Gunter's charts are on. Neelam Nayak has raised his hand. You can unmute him. I'm sorry, unmute her.
Yes, sir. Yes, sir.
Yes, Dr. Neelam, you can go ahead. Hello. I'm sorry, I'm not able to look at the charts right now. I'll answer them as we finish. Dr. Neelam, do you have a question for me?
No, sir. Sorry, it was by mistake, sir.
Okay, that's fine. Not a problem. It has to be interactive. Can we have the third question? Third question, Dr. Yasha. So the question is intercartilaginous incision, whether it is same as the transcartilaginous incision. Yeah, I mean, I'm seeing great answers. All of you are well educated. That's so nice. So nice to know. I think 75% has voted now, and it's not moving further. You can end the poll, Dr. Shriyasha. Yeah. So you can share the results with them. Most of them are saying yes, they are not the same, they are different. So that's the right answer. Two people have said yes. The confusion is because of the multiple terminologies that we use, especially with the incisions. Now, always you need to break down the rhinoplasty surgery into multiple steps, and always every single step is as important as the whole surgery. You can take a photograph of this slide because these are the sequence in which the rhinoplasty flows. There's no other sequence. Possibly one or two here and there might move up and down as per the preference. Now, essentials are a loop, which we use in facial plastic surgery, a fiber optic light, and no instruments. Anesthesia, both general anesthesia and locally by injecting it, especially with adrenaline. You wait for about 15 minutes for the swelling to come down. What happens is as soon as you inject, it might not be acting, plus it will bulk up the nose and you will have a wrong analysis when you start doing it. So you better allow it to settle down. Of course, remove the intranasal pack, shave Vijayydev, and put your incisions. And once you put your incisions, go to the exposure of the skin envelope. So go up to the radix and expose your nasal dorsum. Then go for the septal exposure. Expose the septum if you want to harvest the septum or do something at the septum only. Reassess the operative plan based on the alar and septal anatomy and create the symmetrical alar strips. I'll tell you what it means later. And then you do the hump reduction or the bony work. Then come down to the caudal septum. You can take out the septal harvest after the caudal septal excision or after excising the hump part. Osteotomies can be combined along with this. Then you prepare a graft, start doing the mid-vault work. So it's a top to bottom approach. So do the bony work first because you don't want to be hitting with the mallet once you have done the fine grafting below. Spreader grafts, then columnar strut sutures, tip grafts, and the last should be the alar base and the alar base modification. And then you put the cast and put packs or Doyle sprints inside. So incisions in rhinoplasty have been asked many times. I think this next photograph will clear many of your doubts, but for now I'll just tell you the main difference between open and closed rhinoplasty. Open rhinoplasty means you open the structure or the cartilage entirely in view. Closed rhinoplasty means you still open the cartilage and see it, but you are going to have a envelope in front which you have to move to the side to visualize the cartilage. As simple as that. So you do not have any interference in the open rhinoplasty. Something like this. So in this you can see that the entire cartilage envelope is seen. When you have opened it, you can see the bony side and the K area, and you can see the upper laterals. You can see the lower lateral cartilage as well. Now that is the open rhinoplasty. Now the second thing what you're seeing here is the closed rhinoplasty, wherein you can see that they have delivered the lateral crura of the lower lateral cartilage for doing the surgery at this point, or for doing the tip surgery. Especially if you're doing mid-third or you're doing work at the bony dorsum, you might not even be able to open like this. You'll need to put your Killian speculum and look inside and do the surgery. Only you will be able to deliver the tips like this and do the surgery. That is open and closed, because we are not going to debate on that because they have their own merits and demerits. Okay, so this slide is important for you. You can take a photograph of this. The intercartilaginous incision is always between the upper lateral and the lower lateral crura. Transcartilaginous is going to cut the cartilage and go up or go down, while as the infracartilaginous at the margin of the cartilage, we do not do this incision nowadays. We use more of the marginal incision which follows around the fibrofatty tissues. Rather, we do not follow the cartilage margin because we need this additional space for grafting. Okay, or if you have to reposition your cartilage down, we need this additional space and the fibrofatty tissue. So we do not go on an infracartilage, we go on a marginal incision. Okay, now this marginal incision is also part of the open rhinoplasty along with the transcolumnar incision. So you put a columnar incision, you have a vertical limb and a marginal incision to expose the entire framework. So additionally, you can have outside the nostrils, you can have an alar incision for alar surgeries as well. Now herein I can show you the incision here shown here is almost transcartilaginous. If you go a little beyond, it will be the intercartilaginous, and this will be the marginal incision. The transcartilaginous can be here as well, but this I'll just remove those red marks so you will be able to see clearly. Can you see it's almost on the cartilage itself? So it is better to know what's transcartilage. Transcartilage is on the cartilage, intercartilage between the cartilage, margin is lower and the lateral cartilage or the caudal end of it. So I just want to ask one question here. There is a in the lower lateral cartilages. Can anybody point out what this body is? You can unmute yourself and answer. I mean, I just want to keep it more interactive. I'm not able to look at the chat, so please unmute yourself and tell the answer. If you're wrong, that is okay. I mean, we have all made mistakes. Whatever strikes to you immediately, whatever immediately strikes to you. There are many points there. I can talk to you for half an hour about that, but still.
So kindly repeat
what
the
strikes
question.
to you? What do you see?
Yes.
Yeah, I'll just rub out all those lines and just mark. See, what is the deformity that you immediately see on this lateral crura as soon as you see? What is the most? You can unmute yourself and answer. Please feel free to unmute yourself and answer. This is yeah, please go ahead. Yeah.
So the left is higher than the right.
Okay. Anything else?
Sir, is it a hump, sir?
Hump. Okay. Hump, I will usually think of at this point, at a higher point.
Yeah.
I'm still looking at the lower lateral cartilage. Just about the lower lateral cartilage, you can comment.
Boys, yes.
Higher than right.
Yeah, anybody wants to comment on that?
So the left dome is higher than the right.
Okay, if you look at the points where the skin hooks are attached, one is lower, one is higher. So that might be a false analysis. What has
LR
actually
stenosis.
happened here? I will just. What stenosis?
LR stenosis, sir.
Alar stenosis. No, we're not able to look at the nostril, isn't it? So it's
Yeah.
difficult for us to analyze it. Just looking at this cartilage, normally I just draw on this. The cartilage medial crura should be like this. Lateral crura should go in this fashion. Lateral like this. If it is going towards the midpoint of the tube, or if it is going towards the canthus, we call it as a lateral crural malposition. Okay. You can see it here on the right side. You can see it coming here. Instead of going in this fashion, you can see it going here. Can you see that?
Yes, sir.
Okay, so this is just for you to evince interest in what can be seen intra-op, also what you might not see in the before pre-operative photograph. I hope it was clear. Now you can take a photograph of this slide. Many times you get this question: what is a blue staircase, low columnar, gullwing, inverted V, inverted gullwing, all this. These are all transcolumnar incisions. All of them are transcolumnar incisions.
Sir,
We are
your
cutting
voice
across.
is breaking, sir.
I'm sorry. We
Sir,
are
your
cutting
voice is
across
breaking.
the column. I'm sorry.
Sir, can you close your
Yeah.
video and yes, sir.
I can close my video. Yes.
Yes.
Okay. Can you see? I'm sorry. Yeah.
Yes, sir,
These
we can
are
see.
all called as transcolumnar incisions. Okay. Why is the transcolumnar incision never designed as a straight line? Because the human eye has a tendency to see straight lines from anywhere across the world. And once it is a straight line, it will obviously notice. That's why you break the scar into multiple fragments. You don't have the scar in one line, you break it into various fragments. That's when it becomes a broken line scar. The second point is you always have the narrowest point of the scar towards the narrowest point of the columella. So that does not get highlighted. And so these are the possible incisions that can be done for transcolumnar. Now, once you do these incisions, you open the envelope with another vertical limb and then the marginal incision. That becomes an open rhinoplasty incision. So far, we have covered close to all the questions that Dr. Sriyash and Dr. Pratik wanted me. There are few more things that I can teach you on the way, but we are also delayed for time. So I just want to know if you're okay in time to do for another 10-15 minutes.
Yes, sir. Yes, sir. Please, sir.
Okay. So anybody can unmute themselves at this point and ask me if you have any doubt before we proceed further. Because the next few slides are going to be analysis by you guys only. So you need to raise your hands, unmute yourself and speak. Any doubts so far? Okay, that's
Hello.
fine.
Excuse me, sir.
Yes, please go ahead.
Sir, what is extracorporeal rhinoplasty?
Yeah, so intracorporeal is all the rhinoplasties we do on the septum, keeping the septum inside the nose. As soon as you take out the majority of the septum outside, design it and put it inside, then it is called extracorporeal septoplasty. Okay, does that clear your doubt? Yeah. Anything else?
Sir, can you tell us about in detail about the triangles in the anatomy of nose? We know it by theoretically, but practically we don't know exactly where it lies. Empty triangle, soft triangle.
Oh, you want to know about the soft triangle? Okay. So this here point, can you see what I'm drawing? Can you see that point what I drew on the screen now?
Yes, sir.
Yeah. So this point is devoid of any kind of cartilage. The reason is the medial crura comes up like this and turns upwards. Okay. It does not turn downward like this. So this point is devoid of any kind of cartilage, and that's why it is called as the soft triangle. What other triangle were you asking about? Sorry, I didn't get that part.
It's an empty triangle.
empty triangle. I think soft triangle is also the empty triangle. I am not very sure. I can look it up for you and get back to you.
Okay, sir. Okay, sir.
Okay. Another important point that they might ask you is the ligament of Pittangai. Okay, that's the ligament which attaches the subdermal tissue to the interdermal tissue. So it keeps the definition of the tip. So I just go back a few slides and show you where it would be attached. So the ligament between the subdermal tissues of the tip and this would be the ligament of Pittangai, which we usually cut and expose the mid-dorsum. Okay. Any other questions before I can proceed?
Sir, weak triangle.
Sorry?
Weak triangle.
Yeah, I'm not sure. I'll get back to you. Weak triangle, is it?
Yes.
No, I'll get back to you with that. I'm not very sure about that.
Sir,
Okay.
the ligament of Pittangai, can you please repeat what? The subdermal tip to what it connects, sir?
Interdermal tissues.
Okay.
Interdermal. These are the domes. So interdermal tissues, and sometimes it sends out ligaments across to the domes as well.
Okay.
So if you cut this area here, then you can reflect, or you can even do the surgery without cutting the ligament of Pittangai. It's actually going to be quite difficult.
Okay.
Okay. Anything else?
Mathematical approach.
What scientific है rhinoplasty?
Yeah. Can I proceed?
Yes, sir. Yes, sir. Please.
So anybody can volunteer. What do you see immediately as soon as you see the nose? Just feel free. I mean, this is a class. I mean, I don't want you to be sitting silently and just watching what I am speaking for the last 1 hour. It would be better if you tell something. I don't know who you are, but I would love to listen to your voice and at least know whether I'm making any sense. What do you see as soon as you see the nose?
So vertical deformity, sir?
Yeah, you can see that there is a deformity of the nose. External shape is deformed. All of you agree on that? So let's go to this. I will blank out the lower part. What can you see now? The upper third is also deviated. But if you go back to the previous slide, you will still feel that only the lower part is deviated. Can you make out now what I'm trying to convey to you? Hello?
Yes, sir. Yes, sir.
Yes, sir. Yeah. So you will need to blank out the part of the nose and see it in individuality. So you will see that the upper part is also deviated along with the lower part. That is, the lower 2/3 is also deviated in one angle, upper third is also deviated in one angle. But as soon as you see, you will start thinking that only the lower part is deviated going towards one axis. So you need to address both these things at the same time. So you will need to do surgery at the K area as well to get this alignment better. Okay. So you need to rasp as well to remove the mild hump that you're seeing here. Okay. So what problem do you see in this nose? This used to be the trend in the United States earlier, and people wanted this kind of bone. This used to be called as the ski slope deformity. Ski slope deformity. It's to slope like a ski and be pointed at the tip. Nowadays, this is not the preferred look. It makes the nose looks very short. And can anybody tell me what the problem is? Can you see my cursor where I am moving it?
Yes, sir. We can see, sir.
Yeah. Can you see what's the problem here? Please feel free to answer. I mean, I know it's late in the night, but only if you answer will I be able to help you. People answering on the chat. Okay, you're saying it's radix and a low radix. Very good. And possibly a bit of the mid-dorsum as well. So that's not what we want. Depression you feel is too much. Yeah, you feel it's too much. Okay. So we can correct it, the radix, and correct it better as I showed you. It should be opposite the supratarsal crease, and this is the postoperative photograph. Next thing is you can put grafts in the radix area. Now, what kind of graft can you put in the radix area? What can you put in the radix area? Anybody wants to answer that? Do you want to put cartilage there? You want to put anything else in that area? People can answer. I think the chat window is not coming up there. Okay. Dice cartilage, some of you say dice cartilage. Okay, very good. Anybody else? Dr. Roshan Bombay saying, yeah, that's a good one. But then what happens with dice cartilage is there is nothing to bind it. If you're having a dice cartilage fascia, it may be better. Also, you will need to account for the loss of about 30%. So you will need to overdo it. Yes, you can do fascia as told by Dr. H. Shah. And crushed cartilage is one of the options because it maintains its contour without having much of resorption. Fascia is also a good option. Fat is also a good option. I'm sorry, voice is breaking, but try to be much more slower. So the options before us is dice cartilage fascia, only fascia, crushed cartilage, and fat as well. Okay. So go to the next slide. So what problem do you see in this patient? Something which strikes you immediately as soon as you see the nose.
Alar flare.
Good. LR flare is there. Excellent. Anything else?
Tip projection.
Tip projection, maybe we better comment on the profile view. Frontal view, it's
Mid-dorsum is more flattened, sir.
okay. Okay. So you can see what strikes you the most and what the patient did not like was these points. Okay. He felt the cartilage was, he felt the nose was too pinched at that point and he didn't want. Of course, the alar flaring is more. It is more than required. Alar base is also wide enough. But this is a very close-up view. I wouldn't say that's the best view. So you can actually correct this. Again, I did mention to you about something called as a lateral crural malposition. This was a lateral crural malposition and it can be corrected in this fashion. Okay. Are you getting what I'm trying to convey? Because unless you understand the deformity on top with the deformity below, it won't make sense to do a rhinoplasty. Okay, I'm just trying to run through a few photographs so that you know what we are speaking about. Okay, and some amount of grafting to the radix as well. So problem with this lady, it's quite obvious. What is it?
Saddle.
Saddle is there. Radix is also low. So my question next to you, I think that's the fourth or the fifth poll question.
Eyebrows
Fourth question. Yeah, you feel that the eyebrows are too thick, right? Okay.
Yeah.
And you can see that the eyes are wide set apart.
Yeah, telecanthus.
Yeah, telecanthus. So it's more of a pseudo telecanthus. Why? Because this bony dorsum here is too low. Okay, yeah. So it's a pseudo telecanthus, right? I'll just go to the next slide. So this is how it looks. Does it look as like a saddle now or a mid dorsal deformity? It's not much of a saddle, I would say. It's more of a mid dorsal deformity along with the radix deformity. So that's why you need to always look at the profile. So if I'm supposed to graft this patient, okay, what would I be using? Okay, I can use various grafts. Can you play the poll 5 question, Dr. Sriharsha? I think it's poll number 5. Just a minute, let me see which was that question that we were. Yes, question 4. Can you answer this, please? Excellent. Nice to know that more and more people are answering. So those of you who have not clicked your mouse or you have not clicked on the screen, please go ahead. Feel free to answer.
It's 7, sir.
It's on the poll right now. Okay, so do you want me to end the poll now? Okay, you can end the poll now. So there is a mixed answering. See, the 4th, 5th, 7th, 10th, that's the question. Of this, the most commonest we would want to use, most preferred, is something which is outside the purview of the pleura and not closer to the peritoneum. Most of you have answered 10th rib. Of course, it is closer to the, far away from the pleura, but you can risk going down. Why the 10th rib might be preferable is if you are harvesting the fascia at that point, then you can, rectus fascia, then you can take the 10th, but most of us prefer to take the 7th or at least the 8th rib. So this is what is preferable. 4th and 5th we might avoid because it's closer to the pleura, though you can get a thicker chunk. But what happens in thicker?
And in sir, they are also straight ribs, so it's easy
Yes.
to make the framework of nose.
Yes, correct. That's good. Okay, so can you close the poll, please? Yeah. So going on to the next. Okay, so you can give a good augmentation with the cartilage placed on top. And now you can have this patient here with the external nasal deformity. You can see a very, very thick lower third, isn't it? So what could this thick lower third be due to? Anybody wants to answer? Can you see that bulge out there? What do you think that bulge is due to? I'm sorry, so many people are answering on the chat. I'll have to follow both the things, the chat and this. Fibrosis, malposition, alar cartilage rotation. Okay, just hold on. No, I'm not talking about the cause. It is just that the lower lateral cartilage, lateral crura, is very, very wide and convex at that point. That's why it is showing bulbous at the top. Okay, that was what I was trying to get your opinion from. And she also has a hump deformity here laterally. That means the septum has moved to the side, carrying along with it the lateral crura as well. So you need to do osteotomies and then move further to get a straighter profile and a narrow tip along with the definition of the lateral crura. We can do something called as a cephalic trimming by retaining 6 to 8 millimeter. Please note this, you retain at least 6 to 8 millimeter of the lateral crura after doing a cephalic trim. In thinner cartilage, you retain more. Thicker cartilage, you retain lesser. Okay. Also, you do something called as strut grafts to make your septum straight. Earlier, it used to be a point of lot of scoring of the cartilage to make it bend. We don't use those scoring incisions at all. We use something called as a strut graft or a batten graft. So it is something like a splint wherein you keep the batten graft beside the bent cartilage and put 3 stitches, one on the extreme, each extreme of the fracture line or on the bend, and one at the center. You can see those 3 suturings here. This is how a batten graft has to be placed. So this was just for a rib osteotomy point. You can see that the mid dorsum looks quite wide, not only because, I'll just show you the profile view. I'm sorry, I don't have that. The profile was not low, but it looked wide because her bony dorsum was wide enough. So you will need to do a low to low osteotomy to get this whole thing inside and angulated. While the previous one was to get a symmetry, this one was to get the narrowing. So I won't go into the middle 1/3 or the middle vault. We can retain it for a later discussion because that is going to be another 1 hour or so. Dr. Sriharsha?
Yes, sir.
Yeah, because a lot of points to be discussed in middle third and then we go on to the lower third. I'll just leave you with this last one slide. So rhinoplasty is not about refining whatever is there. It is to do with refinement meant to match the face, meant to match the smile, meant to match the personality. So if you go on reducing, do multiple surgeries, the nature also will take its toll and heal in very, very unpredictable manners. So this is not what we want to end up with. And so all of you who want to become facial plastic surgeons like us, you are welcome to our field. Go through a good training program and we'll guide you in the future. Thank you. Thank you so much for a patient listening and all the interaction. Can we play the poll questions, please? I think that's important. I need to explain a little things.
Yes, sir.
Can we play the poll questions? Yeah. Question 5, please. Yeah. So goods ratio, what does it measure? Does it measure the alar base width, the nasal tip rotation, tip lobule projection, lip width? Good. Still 41 people listening into the talk and learning from us. Thank you so much. Okay, we can close the poll now. So you see my drawing on the screen, all of you? Can you see the drawing on the screen?
Yes, sir.
Hello. Yeah. So this is the alar facial crease, the facial crease, okay, in the profile view. Facial crease to the nasal tip and nasion to the nasal tip. Okay, if you take this as X and this as Y, it should be 55 to 60 or 0.5, 0.55 to 0.60. That is the goods ratio and it measures the nasal tip projection. Okay, the next poll, please. So what does preservation rhinoplasty mean? So this is a new term coming up. I'm sure this will be one of your questions sometime in your OSCE exam. What does preservation rhinoplasty mean? At least majority of the times. I'm glad so many of you are attending the webinars and you've heard to all these things. It's so nice of all of you. 70% of them have answered. Excellent. That's great. So preservation rhinoplasty is a new concept that has been coming in now, which was always there, but nobody had actually made it famous. So now a group of surgeons have made it famous. It's basically very, very simple. So if you imagine that a patient has a hump like this, can you see what I'm drawing? I'm sorry, I'll draw it elsewhere. Let's say a patient has a hump like that. Okay. Now, instead of resecting the hump and the bony and cartilage on top, what they're doing is they're resecting the bone on the side of the nasal bones, and within the septum also they're resecting it in such a way that the cartilage drops down and the bone drops down, but this edge is also going to drop down with it. So you are preserving the top part of the dorsum, but removing the bone lower down and the septum inside lower down as well. So the main thing that is being retained here when you're operating is, of course, the dorsum and the ligaments which are preserved. So preserving ligaments may be the more better answer. Obviously, there's no correct answer to this if you compare the ligaments and the other things, but bones, cartilage and incisions are the wrong ones. We don't preserve any bones or cartilage. We remove as is required. Ligaments would be the most appropriate answer, no, although not the very correct answer. Okay, next poll, please. Yeah. Sutures usually used in rhinoplasty on the cartilage. So I'm very specific. It's on the cartilage. So we can see that almost 75% of the people have answered, and the majority of the answer is, you can share this results by closing the poll. Majority of the answer is towards PDS, but still 26, 16, 13. So almost 50% of the people still feel proline, vicryl and catgut. That means to say a lot of you are still yet to see rhinoplasties happening at your center. So good that 50% of you are already having exposure to rhinoplasty and the webinars and the live surgeries and all that on YouTube. But PDS is the preferable one because it dissolves in 3 months and it retains the scar until it matures. So why do we use PDS? I could have used vicryl, or I could have used proline. Proline stays in the long term. If it's blue, sometimes it shows through thin skin. It can get extruded. It can get infected. Vicryl has a chance of infection more than PDS. Vicryl stays shorter. PDS stays for about 3 months to 4 months, and then it waits till the scar maturation happens and then dissolves away. Catgut, yes, the reactions are more, infections are more, we don't use it. And thankfully, PDS stitches, nowadays we're getting colorless stitches, so we can use it on even the lighter skin as well. Okay, I think we can close the polls for today. Hopefully you had a fruitful learning from the OSCE session today, and covered as many topics as possible. Whatever questions you want, I can answer them right now.
Sir, we have few questions about, can you explain different osteotomies?
Yes, sir. Osteotomy, please, sir.
Yes, sir. Just hold on. So I'll try to draw it here. Just hold on. I just removed the pen. So what else do you want me to explain? Just list it out, please. So if this is the nasal bone, okay, and this is the septal assembly here. If I carry forward the incision in this fashion, it is a median osteotomy. If I carry forward the incision which is fading outward, it's a paramedian fading osteotomy. If I do a cut across the nasal bone, it is called as a root osteotomy or a transverse osteotomy. Sometimes I don't differentiate between the root osteotomy and the fading paramedian osteotomy. I just carry it in this fashion, so then becomes a fading paramedian osteotomy. Whatever I do on the lateral side is a lateral osteotomy. Okay, this is the basic terms, right? Now, if you look at the profile, this is the nasal bone. Now, that is attached to the frontal nasal process of the maxilla. So if you carry forward the incision low, that is near the nasal process of the maxilla, and stay low and meet the transverse osteotomy, then it is a low to low. If you carry this from a low point and you go higher to meet the transverse osteotomy or the paramedian fading osteotomy, then it becomes a low to high osteotomy. Does it clear your doubt? If you do it only for the nasal bone, it becomes a high to high osteotomy. There is another term called as intermediate osteotomy. Let's say you have a very convex nasal bone like this. You do a lateral osteotomy, you do a median osteotomy, or a paramedian osteotomy. But unless you do an intermediate cut, this will never come into alignment. So you need to make 3 fragments, rather fracture the whole nasal bone and allow it to heal by splinting. So you will need to do an intermediate osteotomy to be able to get a very convex nasal bone into alignment. Anything else?
Sir, low to high and high to high, can you please repeat, sir? Low to high and high to high.
Yeah. So low to high is when you're involving the nasal process of the maxilla. You can see this is the junction between the nasal bone and the process of maxilla. So when you're going from the nasal process of maxilla way onto the nasal bone across, then it would be a low to high. High to high would be the nasal bone itself. But there is a low to low also, you stay within the nasal process of the maxilla. Yeah.
Thank you, sir.
So it depends upon the type of deformity. Obviously, we are not doing the analysis, so we wouldn't be able to teach you. That is another class, because I was supposed to teach you till incisions. I just whetted your appetite with some photographs. I mean, you are welcome to ask me doubts. I can give you my number. Anytime you can message me, I can. So I'm just putting my phone number there. You can anytime ask me doubts. So somebody is asked about, okay. Lot of questions. Is it? No, I'm sorry. I'm not able to see what's happening there.
Sir, Dr. Navdeep is asking about what are the views of photographs one should take before doing a rhinoplasty?
5: frontal, profile, basal, helicopter view, and I think I missed one, oblique view.
Oblique, okay.
How to make sure internal nasal wall is patent by the end of rhinoplasty? You need to make sure that you address the wall area, you address the, internal nasal wall will get compromised by 3 points. One is the septum itself, one is the lateral wall, and the springiness of the cartilage. So make sure the septum is straight, make sure the wall is open, any lateral wall deformities needs to be corrected, and make sure that there is a space between the two, or the internal wall area angle is also well spaced. Dr. Kapil, I can answer you that in a long way. If you have a main question in mind or some long question in mind, I can tell you how to answer that. What was the last view? 3/4 view. 3/4 view.
Sir, it was in more relation of spreader graft.
Okay, okay. See, the concept of spreader, the concept of valve is changing. For now, for you people, just mention spreader graft and make sure the septum is straight and the lateral wall deformities are taken care of. For example, imagine I put a spreader graft, but the lateral wall is pinched in like this. Okay. We will need to make something for the lateral wall to move apart, isn't it? Spreader graft alone won't move it. We need to do something there. So there's a lot of things. You need to put a graft or a titanium spring, a lot of things coming up. Hopefully I can answer you all that. I have put down my number. If you want, I'll put down my mail ID as well. So you can ask me questions whenever you want. I'm sorry, I'm trying to end here because I need to close the session because we've already made it 1 hour, Dr. Shriyasha.
Yes, sir, approximately. But it's okay, sir.
Yeah.
Yes, sir. Sir, thank you for the excellent presentation, sir. Actually, I also learned so much about rhinoplasty. So, thank you so much, sir. Thank you so much
You're
for.
welcome to visit me during the surgery, Dr. Pratik. We both work in the same city.
Yes, sir. Yes, sir. Yes, sir. Thank you so much for giving your precious time, sir. If we have any doubt, I will also forward you some questions, sir, so that
Yes,
we can
please.
post it on the group, sir.
Yeah, I mean, I just want a feedback, if you can.
Yes,
design
sir.
the last poll. Dr. Sriharsha or Dr. Pratik, you can design the last poll.
Yes, sir, we can.
The questions could be, was it useful? And then yes, a no, and a maybe. That's enough.
So we can ask members right now also.
I mean,
They can
rather than see
answer
the
in the
chat.
chat. Yeah.
Yeah, the statistic is more important because that is what tells us really with what we did, rather than putting it out on the chat. You can possibly, if you can, design.
Just a minute.
Yes, yes.
But thank you for your comments, all of you who are thanking me for the presentation. I hope I was not too fast. I'm really sorry because I wanted to cover a lot of things for you.
So the poll is on. You can. Yes.
Please be very frank with your opinion. Don't have to shy away and say, oh, it's useful, because negative feedbacks are the ones which build us. And I don't want to be thinking, oh yeah, it was great. No, please feel free to say it was somewhat useful. It's okay to be telling that. And no also is fine, because if I have not done it to the expectation of you, I can definitely improve it. Okay, I think you already closed it. But thank you, Dr. Shriyasha. I mean, thank you for that. But I wish I would have seen more negatives also. I need to go back home and work on myself.
No, sir, this was excellent, sir. We want what we wanted. You have covered it, sir. So
okay.
Yes, sir.
I'm glad I could cover it. Anybody has doubts, please feel free to get back to me. Okay.
Yes,
thank you, everybody. And you are the guys who are handling COVID. All of you, the DNB students in the private hospitals, please stay safe. Don't take it for granted. Please wear your PPEs, kits, masks, whatever is required to keep yourself safe. And as per the requirements, take HCQs or whatever, and keep yourself isolated away from your family if you're handling COVID patients as well. Okay. Thank you all, and good night to everybody. Thank you, Dr. Sri Harsha, the Sahasra ENT Foundation, and Dr. Pratik and Dr. Bhagwan. Sorry. Yeah. Bhargav for your help. Okay. And thank you all the students for logging in tonight. Okay. Bye then.
Yes, sir. Bye, sir. Bye, sir. Thank you so much, sir.
Thank you. Bye.
Thank you so much, sir. Bye, sir.